a case in radiology. So we usually start with observation, and then we should do our interpretation, and then mention our main diagnosis, and mention our differential diagnosis, and touch on the management. And the management, we need to suggest if there is any further investigations is needed in the cases, both radiology and non-radiology. And we need to refer to the appropriate team. So, for example, if a patient needs to be seen by the respiratory team, then you should recommend that referral. Medication, you could touch on medication if you're aware or how is the case is going to be treated, and then MDT referral if it's applicable. So observation, interpretation, diagnosis, and differential diagnosis, and then management. So I'll start with candidate 1. So candidate 1, are you here?
Yes,
so
I'm here.
Candidate 1. Yeah, okay.
Yes.
So this is a 45-year-old male who presented with cough, and he has weight loss.
Okay, I'm presented with a frontal chest radiograph of this 45-year-old male with cough and weight loss. There is diffuse reticular obesity at both lung with increased density at the right lower lung zone, obscuring the right heart border. Both highlights are unremarkable. No evidence of pneumomediastinum, pneumothorax, or pneumoperitoneum. I'm going to check the bone.
Yeah, so nothing in the bone.
Okay, the bones are unremarkable. So there is obesity seen at the right middle lung, right middle and lower lung zone. It's also obscuring the right hemidiaphragm. So I think it is within the right middle lobe and the right lower lobe.
So what's the general pattern? So you said reticular. Can you see anything else?
Yes, there is diffuse reticular obesity.
Yeah, and what is it causing? Does it cause anything in specific?
I think there is some cysts seen. You can see some cysts at both lungs.
Can you see these tiny things here? Like I'm just pointing them. Yes.
Okay. Yes.
Yeah.
Yes.
So does it change? Yeah. What do you think?
Yeah. Okay. Giving this appearance of reticulonodular obesity, it could be patient with the weight loss.
Yes, patient with the weight loss and chronic cough.
Okay. So it could be lymphangitis carcinomatosis.
Okay.
Of cancer, or it could be.
Okay. Yeah, go ahead.
It could be sarcoidosis.
Okay.
And
so what's the general pattern? So what do you call these type of nodules?
Could be miliary nodules.
Yes, so they are miliary nodules. Can you see them? They're quite tiny, scattered all over. So
yes.
What's your differential for miliary nodules?
TB or
TB.
tuberculosis infection.
Yes, infection. Yeah.
Or it could be secondary to thyroid carcinoma.
Okay. Yeah, metastasis.
And it could be other infection.
Like?
Fungal
infection. Okay. So, and management-wise, yeah, what would you do management?
Okay, so I will discuss with the referring physician
Mm-hmm.
and request further imaging, CT post-contrast for the chest.
Mm-hmm.
And the patient, we should also investigate for TB infection
Okay.
acid fast bacilli. Okay, and
Okay. Yeah.
the patient is positive, so patient will need urgent isolation and also
Okay.
isolation or investigation of the relatives, contact relatives.
Okay, so this is, yeah, okay, so well done. So this is a case of miliary nodules. So you've commented that there are multiple reticular. It looks reticular, but when you have another look, there are some distributed, just random nodules. You've correctly said that there is no lymphadenopathy, and there is this patchy airspace opacity here. So that's a pointer towards a diagnosis, a specific diagnosis. So if I were to tell you choose one diagnosis, what would you go for?
I will go for TB.
TB, yes. So this is a case of miliary TB. So in the exam, you need to tell the examiner that this is in keeping with miliary nodules. I have a couple of differentials, but I can see that there is an airspace opacity projecting on the right lower zone. So this is likely infective. So you can categorize your differential diagnosis according to infection and then non-infectious or metastatic. So infection, you could go for, and you can say to the examiner, if the patient is febrile, this could be miliary TB, it could be fungal if the patient is immunocompromised, such as histoplasmosis. Patient is well and afebrile. That could be a healed varicella. However, I can't see any calcified, so healed varicella would be usually calcified nodules. Other differentials would be metastatic miliary nodules from thyroid and renal. So it would be thyroid and renal will cause that kind of appearance. And there is other miscellaneous causes of miliary nodules. One of them, you said it, which is sarcoid. So this is a case of miliary TB. I'm just going to touch a bit on the management. So you need to express to the examiner that this is miliary nodule. This is like an urgent finding because patient needs to be isolated, and they do public health notification here in the UK. So patient needs to be isolated. He needs to be investigated with sputum and bronchoalveolar for acid-fast bacilli, and they need contact tracing as well and public health notification. So that's the steps that what they do here for TB. So this is a case of miliary TB. Okay. Yeah, so this is a young female presented again with chronic cough.
All right, so I'm presented by frontal radiograph of the chest of female patient presented with chronic cough. The striking abnormality is radiopacity in the right upper zone, demonstrating loss of volume with hilar pull to upwards. I think that there is this is fibrosis with consolidation. I am thinking that this could be sequelae of granulomatous infection such as TB. I would like to discuss this finding with the referring clinician and inform them that this might be TB, so the patient needs to be tested for TB with a sputum culture. And I will also suggest a CT of the chest to better evaluate this finding and exclude possibility of other differential diagnosis. For example, if that's not infection or if there is additional finding.
So well done. So this is a case of pulmonary tuberculosis. So we can see that there is patchy airspace opacity and it likes the upper lobes. So, and no hilar lymphadenopathy. So that's one of the important negatives. So no hilar lymphadenopathy. And as you said, you'd recommend a CT chest for further evaluation to see the extent of the disease itself and to look for complications of the disease. And you've said management-wise, you'd alert the physician. So this the physician needs to be alerted. And then you need sputum or bronchoalveolar lavage for acid-fast bacilli, contact tracing, and public health notification. So what's the difference between a primary and a post-primary TB?
The primary TB, there is the Jones focus or Ghon's focus, where there is the primary opacity and then lymphadenopathy and lymphangitis in between. But the post-primary TB, there is the cavitary lesion with surrounding consolidation and no lymphadenopathy.
Yeah, that's right. So this is just a slide here to summarize. So we have primary TB and post-primary TB. So primary TB is seen in pediatrics and immunocompromised. And most important feature is lymphadenopathy. And it's consolidation, parenchymal consolidation often in the lower zone. And typically it's subpleural. You can sometimes see pleural effusion with it. Post-primary, these are the adult patients who are immunocompetent. And the most characteristic thing that we see is cavitation. And it affects the apical and posterior segment of the upper lobe, as well as the superior segment of the lower lobe. Okay, so candidate 2, just carry on before we go to candidate 3. So this is an elderly female with cough.
I'm presented by frontal radiograph of an elderly female presented with cough. I see that it is a nodule in the left lower zone. This is most likely nipple shadow more than a true nodule. But other than this, I'm looking for any additional abnormality. I see that there is opacity in the right lower zone that is projecting over the lower part of the right lung. I am thinking that this is could be a consolidation in the right lower zone, and I would like to review the previous, if we have any previous imaging. If not, then I would like to discuss the finding with recommend CT of the chest for better evaluation.
Okay, yeah, so that's the CT, chest CT. I'll just
so this is CT of the chest lung window demonstrating reticular opacities and fibrotic atelectasis in the lingula and the right middle lobe. Actually, the medial aspect of the right middle lobe demonstrate consolidation. There is also lingular bronchiectatic changes, and maybe train bud opacity seen in few sites. So I'm thinking that this is atypical mycobacterial infection because of the characteristic location. So there is trim bud and the pattern of involvement in the lingula and right middle lobe. This is mycoplasma or mycobacterium infection is. So I would like to discuss this finding with a referring clinician and suggest contact isolation and sputum culture for this patient.
Yeah, so well done. You've picked it up nicely. So this is a case of what we call a Lady Windermere syndrome. which is caused by Mycobacterium avum, which is a non-tuberculous mycobacterium. So here, just the giveaway was the linear opacities here in the lingula, if you can see just here, perhaps maybe not projecting well. And there is some linear opacities, as you said, on the left lower lobe. And the giveaway was on the distribution of the changes, which it affects the middle lobe as well as the lingula with tree bud nodularity. So this is Lady Windermere syndrome, which is caused by Mycobacterium avum. So you do test them. Usually sputum won't give the diagnosis. So these patients usually requires bronchoalveolar lavage, and they get treated. So this is a disease which is seen in elderly females who chronically suppress the cough. So usually in elderly patient, but this is, so this is a Lady Windermere syndrome. So well done. Yeah. So next, is it candidate 3?
Okay. Yeah. So this is the chest radiograph of an adult patient, and it's a male patient. I can see that the hilum bilaterally is appearing bulky, especially the right hilum, which is showing that lumpy, bumpy pattern. And the aortopulmonary windlet is appearing convex, and it is appearing effaced. And looking at the lungs for any parenchymal fibrotic changes, which I cannot appreciate much. And I'm looking for if there are any destructive bony lesions. So I cannot see any lytic or sclerotic lesions in the bone as well. Rest, the cardiomediastinal contour and the lungs, bone, soft tissue is appearing normal. So with these findings, an adult male patient with bilateral hilar lymphadenopathy and aortopulmonary lymphadenopathy, I'll think of sarcoidosis as the first possibility, probably stage 1. Without parenchymal involvement, and the other differentials would be tuberculosis, but usually it is asymmetric, and malignancy is very unlikely because it will cause larger masses, which will be a bit more defined with further nodules in the rest of the lungs or in the bones. So my first possibility is a sarcoidosis, and to confirm the finding, I would advise a CT, and also it will correlate with the serum ACE or angiotensin converting enzyme level. And I would talk to the referring physician as well to have an overall clinical view of the patient, if it is a non-patient or not. If it is not a non-patient, I would advise CT, and if it's a new patient, I mean, if it is a already known patient, I would compare with the previous images. If it's a fresh case, then I would proceed with the CT chest for this.
Yeah, so well done. So that's a case of sarcoidosis, and the giveaway, which is the bilateral symmetrical hilar lymphadenopathy. So do you know how we can diagnose sarcoidosis?
Yeah, usually.
Yeah,
usually this is referred to the pulmonologist, and they go for a bronchoscopy or an endobronchial ultrasound and then biopsy of the lymph node.
Yes. So it definitely needs, a histopathology diagnosis, because it's called the greater mimicker. So a lot of things looks like sarcoid, so they need a tissue diagnosis. But yeah, so that's well done. You've mentioned your differentials. You said it could be infection, TB, but it's unilateral management. That's how they manage. So well done. Yeah. So do you want to take this one? Yes, candidate 3.
Okay. So this is a chest radiograph of an adult patient, a male patient, where I can see that there are parenchymal consolidation changes involving the right upper zone with air bronchogram. And apart from that, I can see the right paratracheal soft tissue is appearing widened. Bilateral lower paratracheal soft tissue is appearing widened. And there is mild widening of the carina. The right bronchus is appearing relatively horizontal, probably due to some underlying fibrosis in the right upper lobe. And both hilum, it is appearing mildly prominent. rest of the lungs are appearing normal with no evidence of any mass lesions, and the bones are grossly appearing normal with no focal lytic or sclerotic lesions. So with these findings, again, bilateral paratracheal adenopathy, subcarinal lymphadenopathy with parenchymal changes, the first possibility would be sarcoidosis because of this 1, 2, 3 sign on chest X-ray. With parenchymal changes, that means it goes to stage 2. And I'm not sure if there is an overlapping infection, so for which I would talk to the clinician if the patient is having any fever or any raised inflammatory markers, because the consolidation could be due to an infection as well. So yes, I will think of stage 2 pulmonary sarcoidosis as a possibility, and I would advise a CT if it's a fresh case. And so in the CT, I can see that there are multiple nodular densities which are mainly clustered around the bronchovascular bundles. That is, peribronchovascular interstitial thickening is there. And the interface between the lung parenchyma and the bronchovascular bundle, I think it is appearing a bit irregular. And this conglomerate of nodules is giving rise to, can I see the upper zones again? I mean, it looks like a bit of galaxy sign as well. The mediastinal contour is lobulated, suggesting, confirming the diagnosis of lymphadenopathy. So yes, this confirms the probability of sarcoidosis, and I would refer the patient to the pulmonologist for endobronchial ultrasound guided biopsy and confirmation. Or if it's a known case, I would compare this with the previous images.
Yeah, so well done. So that's, yes, a case of another sarcoid, which is a different stage of sarcoid. Again, we have mediastinal lymphadenopathy as well as the parenchymal changes. So that's upstaged. So we have the stages of sarcoidosis. So do you want to go through them? Do you want to tell us, candidate 3, the stages?
Yeah, stage 1 means there is only lymphadenopathy. Stage 2 means there is both parenchymal and mediastinal adenopathy. 3 means there is only parenchymal changes. And 4th means there is advanced fibrotic changes.
Yes. And do you know how they get treated? What's the treatment?
Yeah, this is usually treated with steroids.
Steroids, yes. So that's right, yes. So yeah, so that's you've picked it up very beautifully, nicely. You've described it very well. CT shows the typical peribronchovascular nodules as well as perilymphatic and within the periphyseal nodularities. So that's, yes, a case of sarcoid. Patient got treated and they got re-imaged later on, and it just shows the improvement, not completely resolved lymph nodes, but much more improved. Yeah, thank you. So well done. Yeah, so next person, who's next? Is it candidate 4?
Yes.
Yes.
I am presented with can you hear me now?
Yes, I can.
Okay. I am presented
Yeah,
with
so sorry to interrupt. Looks like you are candidate 8. The person who's talking looks like you are candidate 8. I'm trying to keep the order. So is candidate 4 here?
I am
Okay,
candidate 4, but this is okay.
Okay, then we will make you candidate 4 just to keep the order.
Okay.
Okay. Okay, go ahead. Sorry.
Really? Okay, thank you. I'm presented with a frontal chest radiograph of skeletally mature patient. I can see that there is bilateral hilar shadows more on the right side. The hilar shadows show eggshell calcification or peripheral calcifications. Regarding the chest, I can demonstrate definite masses or nodules apart from this nodules that extend from the hilum with calcifications. There is no pleural effusion or pneumothorax. The bony framework is unremarkable. So the salient abnormality here is the bilateral hilar shadows with eggshell calcifications. The diagnosis is sarcoidosis on top of differential diagnosis. The other differential diagnosis could be silicosis. I will convey physician and will require investigation for sarcoidosis like ECE and also a clinical history of previous exposure to silica. And the MT discussion for further mention.
Yeah, so well done. So that's just a bilateral calcified lymph nodes, which is eggshell calcification. So you've mentioned that it could be sarcoid. Here in this case, it actually was silicosis. If you would have, you did actually said if there is any exposure or occupational history, I'll be silicosis. So you've said that, so well done. So the main causes of, so how can you differentiate between silicosis versus sarcoidosis versus tuberculosis? Because the three of them causes eggshell calcification. Do you know how to differentiate just from imaging wise?
Regarding silicosis, there is the innumerable nodules in the post-lung field and has calcification more in silicosis than sarcoidosis.
Yes.
The silicosis don't have 1 to 3 sign of sarcoidosis, no paratracheal lymph node here.
Yeah, so yes, so that's right, yes. So TB. Yeah, go ahead, yeah, sorry.
It's mostly asymmetric hilar lymph nodes.
Yes.
May have other parenchymal changes. Okay.
Yeah, so that's right. Yes. So TB, it's usually the calcified lymph nodes in TB tend to affect the mediastinum asymmetrically and unilateral. So TB causes asymmetry and unilaterality, while in sarcoidosis, as we've seen the previous cases, they're actually bilateral lymph node involvement, which is bilateral. And silica, usually there are other signs which calcified lesions or calcified nodules, such as here and behind the so that's what makes it here silicosis. So try and look for other ancillary findings that points you towards the diagnosis. So these nodules here just points towards silicosis, and they would be exposure history. So yeah, well done. Yeah, so this is an elderly patient who presented with cough.
Yes, please. Candidate 5, okay?
Yes, go ahead.
Okay, this is a frontal chest radiograph of adult patient who presented with shortness of breath. I can see there is an pacemaker insertion, which is an which is a unilate chamber where I can see it's probably inserted. I can see also median sternotomy sutures. I can see there is an cardiomegaly. There is an obliteration of the left costophrenic angle in keeping with pleural effusion, also planted of the right costophrenic angle. I can see there is an a bilateral fine interstitial reticulation with capitalization of the pulmonary vessels. In my routine practice, I like to use zooming, searching for any small subpleural lines. You can see there is a fine pleural peripherally lines which is seen perpendicular to the pleura in keeping with an Achilles B lines. So constellation of all those findings, the cardiomegaly, the bilateral pleural effusion, capitalization of the pulmonary vessels, and the Achilles B lines are more in keeping with a congestive heart failure. So I will, I'd like also to check the other lung fields for any other additional opacities. I'm checking also the bones for any associated bony abnormalities. No pneumothorax or pneumomediastinum.
So yeah, summary-wise, what would you do?
I will urgently convey my findings to the referring physician and recommend a proper medical treatment and further follow-up for confirmation of recovery after diuretic use and oxygen supplementation.
Okay, and if I tell you, just have another look. What are the causes of pleural effusion? Can you see another hint that points you towards the cause of the pleural effusion here?
The pleural effusion.
So what simple things? So what do you think? What's the commonest cause of pleural effusion that you know of?
And other than the congestive heart failure, other than
Yes, other than
cardiac cause, a
yes,
non-cardiogenic
other than
cause.
yeah, non-cardiogenic cause. Can you see anything in the left lung base? Can you see anything here?
Yes, I think there is an left lower lung zone faint opacity.
Yes. So what does that? So how would you conclude the case?
So okay, I'd like to compare with the previous images if it's available, and check the clinical history of the patient if has an unknown if there is any evidence of an infective etiology like fever, or the patient is unwell or has a raised inflammatory marker, because it could be an parapneumonic effusion due to an underlying infection, or if the patient has an unknown primary malignancy, it could be a malignant pleural effusion with an underlying pulmonary lesion.
Yeah, so well done. I think you've described it very well. You've picked up, you've commented on the device. You've mentioned the median sternotomy wires. So this is a unilateral pleural effusion, and there is always another finding that points you towards a single diagnosis. So initially you've gone with cardiomegaly. Yes, I do agree there is some, upper lobe ear diversion. But with cardiogenic, not necessarily. It's usually bilateral, but not necessarily. So here, this is just a simple pneumonia, and this is just a parapneumonic effusion. So just look at the images, try and find out what's the cause of the pleural effusion. So well done, and you've managed it correctly. Yeah. So who's next? So this is an elderly female who presented with cough. So is it candidate 5 or 6?
Should be 6. Candidate 6, are you there? If not, candidate 7.
Hello?
Yes, hi. Yes, we can hear you. Do you want
Yes,
to go?
I am candidate number 7.
Yeah, go ahead.
Yes. I have been presented with a frontal radiograph for an adult patient. The main finding I can see that there is elevation of the right hemidiaphragm. By looking into the left hemidiaphragm, it's also appear elevated. There is no pleural effusion. Both costophrenic angles appear clear. There is no changes of pneumothorax. However, I can see that there is multiple tubular air structure seen arising at the superior mediastinum, which could represent a pneumomediastinum. I will correlate with the patient history to see if there is any history of trauma or repeated forceful vomiting. I can see that. What?
Yeah. No history of trauma.
No history of trauma. Okay. I can see also that there is fullness seen at the right hilar area, which obliterate the medial part of the right hemidiaphragm, which could representing right hilar mass lesion. However, I will ask to see if there is any previous images for comparison, or if there is any lateral images. I also noticed that there is a lytic lesion seen in the body of the right scapula, giving the appearance of the right hilar mass. This could be due to metastatic deposit. there is no other metastatic deposit could be seen within the obvious bones. I cannot see any missing ribs within the available image. So to summarize my case, I have been presented with a chest radiograph for an adult patient with obesity in the right hilar associated with elevated of the right hemidiaphragm, which could represent phrenic nerve involvement or phrenic nerve palsy associated with metastatic deposit in the body of the right scapula. I will.
Can you have another look? Can you tell us where is the primary malignancy from this chest radiograph?
Yes, first of all, I cannot see the right hemidiaphragm clearly with the opacity, change of the opacity. It could be due to right hilar. However, I can ask for windowing of the study to see if there is any hidden mass within the right lower lung zone.
Can you see something else? Is there any other clues here? There are two other clues here that give away the diagnosis of the
Yes,
primary.
there is a crowding of the ribs.
Yeah.
I think, yes, there is a crowding of the ribs. I think that there is also destructive of ribs lesion seen in the lower numbers. So it could be due to mass lesion within the right lower lung lobe. However, for better evaluation and confirmation, I will advise to do chest, abdomen, and pelvis CT scan with IV contrast for better characterization.
Okay, so just sit back and have a look. Just look at the whole image, the whole X-ray. Just sitting back.
Yes.
Have you noticed that she's a female?
Yes, this is this could be due to breast malignancy, because I can see that the right breast appear hyperdense than the left breast.
Okay, and yeah, so this is so there is a mastectomy. So if you noted here, that's her left breast and the right breast. You know, sometimes they do like a lobectomy, not necessarily the whole breast, so that's why. But just look for asymmetry. And the other clue here, there are some axillary clips here. So this patient had a previous, so this patient had a previous mastectomy. She had a previous breast cancer as evident by the mastectomy and the clips on the axilla. And she has this lytic bone lesion, which you've picked up nicely. And just having another look at the hemidiaphragm, I think you straight away went and spoken about it. And can you see here that this is called the meniscus sign? So what is that? Yeah, so what does that imply? Meniscus sign?
Meniscus sign indicate pleural effusion at the right side.
Pleural effusion, yes. So if you were to summarize, what would you say?
I would say this is a patient of a previous breast cancer with the history of surgical operation and surgical eclipse is noted. Seen within recurrent mass lesion associated with elevation of the right hemidiaphragm, pleural effusion, and lytic lesion in the right scapula.
Yes, so that's right. Yes, and she has some sclerotic mets here, so she has a lot of findings. So I'd call it, this is a malignant pleural effusion with bone metastasis, both lytic and sclerotic, secondary to a previous breast malignancy. So that's just a malignant pleural effusion. Okay, and management-wise, what would you do?
First, I will immediately call the referral doctor and put her in a fast track chest, abdomen, and pelvic CT scan with IV contrast, and to be discussed with next breast oncology MDT team.
Yes, so she will need restaging. So they call it restaging scan, which is so probably perhaps she's already had CT TAP. So you'd say to the examiner that this patient would require restaging and would require a rediscussion in the breast MDT.
Yes.
Okay, so well done. Okay, so next, who's next? So this is I think just a routine chest X-ray that was done.
Doctor, excuse me, the last case, the left lung base, is there any abnormality?
So the left lung here, is it?
Yes, this one.
Yeah, so this is just a hiatus hernia, a coincidental finding.
Okay, thanks.
Yeah, so this is just a routine chest X-ray.
I can take it.
Yeah, so go ahead.
So I'm presented with a frontal chest X-ray for an adult with a routine chest X-ray, and the most striking abnormality that I can see, it's involving multiple rib fractures, mainly on the posterior aspects of the left ribs. And I can see also there is increased density of the ribs. I'm looking on the right ribs for any evidence of fractures. I'm not sure if there is any in the lower rib fracture. There is some callus formation. This indicates a more chronic healed fractures. I'm looking for the rest of the bone. I can see that there is diffuse increased density of the scapula on the right side. I'm not sure if it is just a projectional. To me, I'm looking from my phone, and I don't see the well outline of the scapula. So I will be worried about the scapular region with the sclerotic lesions concerning for sclerotic metastasis. And the lungs itself, both lungs appears clear with no nodule or mass. You can see there is elevation of the right hemidiaphragm, but I don't see any pleural effusion. So if this is a routine chest X-ray, if there is any previous images, I will compare to see the appearance if this is a new abnormality, especially on the right scapular region. And if this is a new and the patient is a male patient, I will be worried about sclerotic mets from prostate CA. If it's a female
if I tell
patient,
you, yeah, sorry to interrupt. So these are all rib fractures, and that's just an over-penetrated X-ray. So
okay,
nothing in the bones, yes.
Nothing in the bone. So looking again at the lungs and my review areas, I'm looking at the lung apices at the retrocardiac region and the infradiaphragmatic regions. I don't see any obvious abnormality. I'm looking at the hilum. Maybe there is some fullness on the left hilum with left hilar opacity. I don't see right hilar abnormality.
Okay, can you just tell me a bit more about the hemidiaphragm?
The hemidiaphragm on the right side, it appear elevated, but the diaphragm itself is continuous. On the left hemidiaphragm, I can see that there is loss of continuity of the medial aspect of the of the left hemidiaphragm. So that will be concerning for a retrocardiac or left lower lobe obesity. In my routine practice, I will window this a little bit more to make sure if there is any retrocardiac region, and we'll correlate this with the patient symptoms. If there is any lateral radiograph, I can take a look at that. If there is nothing, we'll alert the referring physician and arrange for contrast-enhanced chest CT scan with the main differential is a partial collapse of the left lower lung lobe. In an elderly patients, I will be worried about endobronchial lesions and malignancy. If there is increased...
Okay, so there is nothing else, just for time reasons. So you've picked up nicely that's a raised right hemidiaphragm. What are the causes of the right hemidiaphragm that you know of?
It could be related to phrenic nerve palsy. It could be related to hepatomegaly, or could be just paralysis, like we see it sometimes normal variant. Subpulmonic effusion also can give us elevation of the right hemidiaphragm.
Yeah, okay, so that's just a simple case of elevated right hemidiaphragm. So I've just put it in so we can go through the differential diagnosis. As you said, it could be, lung causes. It could be diaphragm causes, or it could be abdominal causes that's causing this raised hemidiaphragm. So lung causes, any lung causes, what do you know of? So it could be, yeah?
It's like a lung cancer or mediastinal lesions that will cause a phrenic nerve palsy.
Okay, so lung causes would be more of a lobectomy. So if the patient had previous surgery, and then the patient had a removed lobe, so that would be one of the causes. It could be like pulmonary fibrosis, just causing the hemidiaphragm to be much smaller. So that would be the lung causes. And then we have the diaphragm causes, which you said it could be like a palsy, phrenic nerve palsy. So that's one of the causes. Other causes could be diaphragmatic evitration. And then abdominal causes would be of hepatomegaly. It could be metastasis to the liver. So there are multiple causes. So I've put that. So I wanted you to describe that as a raised hemidiaphragm, and I wanted you to go and look at the ribs. There are no surgical clips, no evidence of thoracotomy to indicate that this patient had a previous lobectomy. Other causes, I would think of phrenic nerve palsy, or it could be diaphragmatic evitration. I'd like to compare to previous images and see if that's been chronically present on previous images or not. And then I'd be thinking of other abdominal causes. Okay, so that's just a raised hemidiaphragm.
Thank you.
Yeah, so next. Who's next?
Should be candidate 9. Candidate 9, are you there?
Hi, can you hear me?
Yes.
Okay. So I presented with the frontal chest radiograph for an adult patient, showing that there are multiple small nodules projected over both lungs. I think that these nodules, they are related to the reps. As I can see their borders getting away from the reps, they are in continuity with the reps. Also, I can see prominent highly at the left side. The costophrenic angles, they are normal. There is no pneumo or mediastinum or shadows, so this is likely a male patient. There is no evidence of surgical clefts seen at the root of the neck or the axilla or the scant part of the abdomen.
So if I hear these, just ignore these nodules. So that's not the main finding here.
Where are the nodules? Okay. Okay. Maybe there is an opacity seen at the mid-zone peripherally, laterally. Yeah, this one. It's not causing rib destruction. I cannot see a visible air bronchogram throughout this opacity. There is mild hilar enlargement bilaterally. I cannot see, okay, maybe there is.
Yeah, so you've picked up the opacification, yeah. So what's the common cause for that?
So I will convey my finding for the referring physician and correlate with the clinical data. If this patient is coming with acute onset of fever and cough and shortness of breath, I will correlate with the inflammatory markers. So it could be a pneumonia, pneumonic infection. If not, and this patient is a smoker and coming with cough, it would be concerning for peripheral malignancy of adenocarcinoma.
Okay, so yeah, that's absolutely perfect differential diagnosis. So common things are common, and if I tell you yes, patient has high infective markers, so this is infective consolidation. I'm going to ask you a direct question just to point you towards another abnormality here. Do you think is there any pleural effusion?
Yeah, maybe the horizontal fissure is slightly outlined, and also mild blunting seen at the right costophrenic angle. Yeah.
Okay, so
Cause more with infection. Yes.
and if I tell you the right costophrenic angle, it looks okay. What do you think about this hemidiaphragm?
So it could be subpulmonic effusion.
Yes,
yeah.
yes. So subpulmonic. So what's different about this hemidiaphragm?
It's elevated.
It's elevated, and is there anything in specific to point towards how can you differentiate just from an elevated hemidiaphragm?
Yes, because there is lateralization of the dome of the hemidiaphragm.
Yes.
Yeah.
So this is subpulmonic. Yes. Well done. You've picked up the abnormality nicely, and you've given the appropriate differential, which you said infection. And then we've just I've asked you about the effusion. So this is a subpulmonic effusion, and it's, as you said, it's lateralization of the diaphragm. So it's more laterally. Just comparing it to here. So if you can see here, that's the hemidiaphragm is just completely raised.
Yeah.
But here it's more laterally, and the so whenever you have a opacity, just look for any other causes. So if you're thinking of infection, just look for other complications, which would be could be a cavity, could be pleural effusion. Don't forget subpulmonic pleural effusion. Okay. So well done.
Okay, thank you. Please, Dr.Nuha, can I ask, why do the ribs look like this? I thought, at the first look, I think that there are multiple sclerotic lesions.
I think it's just, you know what, it's rotated. The film is a bit rotated, and just the quality of the film, it's just a bit underexposed.
Okay, thank you.
Yeah, so who's next? So this is an elderly patient who is unwell.
Yes. Okay, you're going to give me a history?
Yeah, so this is an elderly patient who presented with acute shortness of breath.
Okay, I'm presented with the frontal chest radiograph of adult patient with shortness of breath, of acute shortness of breath. I can see diffuse opacity demonstrating white hemothorax of the right lung. As looking to the mediastinum and the trachea, there is no mediastinal shaft, so it's centralized, raising the possibility that I have white hemothorax with central mediastinum suggestive of consolidation. So I would like to ask the patient about constitutional symptoms such as fever and search for previous radiographs, or I can have possibility such as mesothelioma. So I have to look at the pleural border, so if there is a mediastinal pleural involvement, and ask the patient about the history of asbestos exposure. Also, such position is a supine position. It could be effusion, but effusion would like to make mediastinal shift to the contralateral side.
Okay, so if I tell you, look at the heart, do you think the heart, is it shifted, or is it in the middle?
I think no, there is a little bit shifted to the contralateral side.
Yeah, so it is a little bit shifted to the contralateral side. So that, does it make you revise your,
yeah? Yeah, okay. Okay, the heart is a little bit shifted.
Yeah, okay, so what does that point you towards?
It could be a massive pleural effusion causing shift.
Yes,
It could be also there is a collapse of the contralateral side.
Okay, so yeah, so well done. So the giveaway here, it's supine. So this is a supine film. And you've described that there is a complete or homogeneous opacification of the whole thorax on the right side. And one important point that I would tell the examiner, you've mentioned it, okay, which is the trachea, which is central, but the heart is slightly pushed on the other side. So why is this not consolidation? So it's not consolidation because we can see the lung markings. Can you see the lung markings?
Yeah. There's underlying lung shadows.
Yes. So whenever you see the lung marking seen through the density, that indicates that it is adjacent to the abnormality is adjacent to the lung rather within the lung. So that's makes it unlikely to be a consolidation. Okay. So this is just a pleural effusion on a patient who is supine. It just gives this homogeneous diffuse. And just be aware, always note the label of the X-ray, and the mediastinal shift away from the whiteout makes it a pleural effusion. And look at the underlying lung marking, it will tell you whether the changes are within the lung or not. I think I have a CT here just to show you that it just confirms that this is a pleural
effusion.
Yeah, so it is marked pleural effusion on the right side, and there is just a smaller here, left-sided pleural effusion. So just be aware, sometimes it can be very tricky. We can see it here quite clearly, isn't it? So yeah, so that's just a pleural effusion on the supine. Okay, so well done here. Dr. Ismail, shall we stop here? I think we've gone into an hour.
You can continue for 2 or more cases, then we will take a rest. Okay.
Yeah, okay, so who's next? So this is a 30-year-old patient who's involved in a motorcycle accident.
Okay, I think it's my turn. Can I go on?
Yes, yeah, go ahead.
So this is a frontal chest radiograph of an adult patient who has been subject to a road traffic accident. I can see there is a dense collection within the right pleural cavity, outlining the lung, which could be hemithorax. I can also note some fractures of the left lower ribs. The remaining bones, I don't see any clavicular fractures or fractures of the scapula or the proximal humeri. There might be surgical emphysema on the left side. I'm not sure if this patient is intubated. I can see a tube in the trachea. I can't clearly delineate its position.
Okay. So you're talking about this one, yeah?
Yes. I think it's adequately positioned. So in a context of trauma and hyperdense collection, I'm thinking of right-sided hemothorax as well as left lower rib fractures. I would proceed directly to it. There are also fractures of the right lower ribs. The lungs appear well aerated.
What about this lung here? Can you see anything here?
There is some diffuse opacification, which could be due to intraalveolar hemorrhage in the context of trauma. I would like to confirm these findings with a CT scan of the chest, preferably with IV contrast injection. Yeah.
Okay, yeah. So can you see anything here? Just a bit of density here, more density?
I think this is not density, not related to the surgical emphysema. I thought I was seeing some lucencies. I can't really see.
Okay, so what's the number one thing that you'd really, you know what, on these high motor vehicle accidents, what would you be extremely worried about? The first thing you'd,
Widened mediastinum due to traumatic aortic rupture.
yes, so that's the first thing, yeah.
Yeah.
Okay, and if I see here, there is some pleural capping.
Mhm. Yes.
Okay, so what would you think of apart
But
from
together with the left with the right perfusion, I'm thinking of a traumatic aortic injury.
yes,
So this is an emergency that should be promptly communicated to the emergency physicians and the cardiovascular team. Patient should be rushed to the CT scan and to have a CT aortogram if he is stable. Yeah, and the
yeah,
management see
yeah,
according to the site of injury, the management probably would be surgical. The most common site is the aortic isthmus.
yeah, okay. So yeah, well done. So this is a case of trauma. There are multiple findings. So you've picked nicely here that this is a hemothorax. And if you've noted, the heart is shifted towards the contralateral side because that's a hemothorax. This is a opacification, which is in keeping with contusions. You've have you seen this line? Okay, so there is here, you've picked the surgical emphysema. There is this line which is just literally hanging within the scapular area. So this is a malpositioned line. So they've tried to insert a pneumocath. So this is in inappropriately positioned pneumocath. And you've picked up that there is bilateral rib fractures. So there is multiple left-sided rib fractures here. There is some rib fractures on the other side. There is some posterior rib fractures. So what would you be worried about?
Flail chest.
Flail chest.
Yeah.
Yeah, so flail chest. So, okay, and there is also bilateral pleural capping. So this is, that will make everyone quite twitched about aortic trauma. But if I tell you the patient is pretty okay, stable, then you'd be thinking of other causes of the pleural capping. So here there are multiple findings. I just wanted you to pick that this is a hemothorax with mediastinal shift. There is a malpositioned line. There is a flail segment. So I think I'll come to the causes of apical capping. So we've mentioned one of them, which is a traumatic aortic injury. Other causes, it could be like a mediastinal hematoma. It could be secondary to the rib fractures. So I think the next case here, yeah. So who's next? So that just a companion case with the previous one, and then we can have a
Yes.
break here.
Okay, yes,
Yeah, do you
doctor.
want?
I'm
Mhm.
provided with a frontal chest X-ray, which I can see there is opacity in the left lung upper zone, and both okay, right diaphragm is slightly elevated in compared to the left, and I can see there is a mediastinal widening uh, on both sides, and the heart is also slightly enlarged. So, in summary, uh, I this left opacity in the left upper zone opacity, this could be any consolidation or mass lesion, or could be apical opacity, apical cap. So I would inquire about the patient history.
So this is a trauma. So this is another case of trauma.
Okay, so in the case of trauma, with these finding like mediastinal widening and left apical cap, I would suspect the great vessel aorta injury. So I would further advise for CT scan, CT aortogram for further evolution. So I'm provided with CT aortogram. There is, I can see bilateral pleural effusion with basal collapse consolidation, and there is
So you were suspicious that there is a widened superior mediastinum and there is
yes.
a pleural capping, yes? So you said you're worried about aortic injury. So comment on the aorta here. Can you see any
No,
traumatic?
aorta, no. In the aorta, there is I cannot appreciate any a defect or extravasation of contrast. I can appreciate multiple vertebral fractures are there, and but I can appreciate some hypodensity in the mediastinal region. That could be hematoma. So
Okay. So what do you think is causing the pleural capping in this case?
pleural capping is due to the fractures or because yeah.
So it's just simply due to the fracture. So this is a case of apical capping. So we said we're always in trauma. We need to be very alert and put aortic injury as the first stop differential, but there are other causes of apical capping, which is could be due to, you know, in this case here, it's just the spine. Look at the spine is just completely gone. So severe upper thoracic spine injury will cause mediastinal and extrapleural hematoma. So that's one of the other causes, but always put aortic injury as your first stop differential. So I'll just quickly recap. I think, yeah. Okay, so I'll just quickly recap what we've seen. So we've seen this is a case of miliary nodules, and we said to look for other ancillary findings to give the giveaway diagnosis. Here there was opacity, so that gives the miliary TB. If I see clips within the neck, then it makes me think that this patient had a previous thyroid malignancy, and that's the cause. So always look, when you find one finding, try and look for the cause. So that was a case of miliary TB. That was a case of just a pulmonary TB, and we've gone about the difference between primary TB and post-primary TB. So that this is really important for the exam. And that was a case of Lady Windermere, which is Mycobacterium avum in elderly patients. That was a case of bilateral hilar lymphadenopathy, which we've discussed about sarcoid, and we've gone through the different stages of sarcoid and how you differentiate between all the stages on imaging and on CT. This is a case of bilateral egg-shelf calcification and egg-shelf calcification, and we've gone through the differential diagnosis, which we said it could be sarcoid, it could be silicosis, it could be TB, and we've seen how we could differentiate between the three causes on the imaging, and we said these scattered calcified makes it more of silicosis, and sarcoid gives bilateral symmetrical, and TB gives unilateral lymphadenopathy. That was a case of just a simple pleural effusion, which is a paraneumotic pleural effusion. So whenever you see a pleural effusion, try and dig and look for the cause on the X-ray. So it could be cardiac, or it could be like infective cause, which is paraneumotic effusion. This is a malignant pleural effusion in a patient with breast cancer who had a previous mastectomy. So that's just a simple pleural effusion. And here it's just the meniscus sign is the giveaway. There are other clues that just gave the diagnosis of malignant pleural effusion. This was just an elevated right hemidiaphragm, and it's just these kind of cases, they are in the exam for discussion purpose. So there is nothing, it's just an elevated hemidiaphragm. So the examiner wants to know how you're thinking about it. So we said there are some lung causes, there is diaphragm causes, and there is abdominal causes. This was a case of opacity here, which is common things are common, which is infection. And then there is lateralization of the hemidiaphragm that makes it a subpulmonic effusion. Again, this is just related to infection. And this is the supine position. And this is just a pleural effusion, massive pleural effusion on a supine. So that's how it gives the opacification of the whole hemithorax. And we've said, look for other clues, which is mediastinal shift. and we said to comment on the lung markings. That will tell you the difference between consolidation and effusion. That was a case of a trauma. It had a lot of findings, but again, this is just how the hemithorax appears. And we've discussed about the apical capping. The most important thing when we see apical capping, we need to be worried about traumatic injury, aortic injury. And this is the second case of another pleural capping with widened mediastinum. Again, aortic injury is the top differential here. But when we went to the CT, we've looked at the aorta. We said, oh, the aorta looks okay. So I need to think of other causes that causes apical capping, which is here in this case was the vertebral fracture and the mediastinal and extrapleural hematoma.